Hello, welcome back to my channel. Today, I want to share one of the major systems of MRCP Exam, that is cardiovascular systems. And I'm going to share knowledge, facts, and guidelines about cardiovascular system by reviewing some topics and some questions commonly asked in exam. Okay, let's start with this scenario. If you look at this, here, a 56-year-old man with left ventricular systolic dysfunction was dismissed on climbing stair, but no arrest. The patient was comments on ACEI like ramipril and furosemide. Which on the following drugs would improve the patient's prognosis? Okay, the key point here is LV systolic dysfunctions, and current symptoms is dyspnea on climbing stair, and already on ACEI and diuretics. Okay, so the questions are which one of the following drugs will improve the patient's prognosis? To answer these questions, we must know the congestive cardiac failure by means of acute and chronic heart failure. This is the questions about chronic heart failure management. So to answer these questions, let's review some theory and guideline background here. Let's start with some pathophysiological changes happens in heart failure. This is the neurohormonal changes in heart failure. Here you can see the activations of renin-angiotensin-aldosterone systems and the enhanced sympathetic activities. Because of reduced cardiac output, there is reduced renal blood flow, also renal plasma flow. There is activations of renin by the jugular glomerular apparatus, which convert the angiotensinogen into angiotensin 1. And then it is converted into angiotensin 2 by the actions of angiotensin converting enzyme ACE. And then angiotensin 2 has the effect on vessels like vasoconstrictions. And at the end of RA system, there is formations of aldosterone, which can cause salt water retentions. This is the main mechanisms in congestive cardiac failure. Also, there is the enhanced sympathetic activity. Cause of cardiac output, there will be the reduced blood flow to systemic circulations as well as venous retention, reduced in the preload and the afterload. So there will be increase in the heart rate. Okay, cause of sympathetic activity. So these are the mechanisms. In other words, it's the protective mechanisms for compensations of heart failure. But in this case, heart failure is the progressive decline of cardiac output. So this is no more the protective mechanisms. That's will be the effect of heart failure. Okay, so let's see. Here, there is the enzyme that convert the AC angiotensin 2 1 into angiotensin 2. This is ACE. So if we block angiotensin converting enzyme, there will be no more angiotensin 2. There will be no more vasoconstriction effect. And also angiotensin receptor blockers, there will be no more vasoconstrictions. And there is formations of aldosterone. If we block with the actions of mineralocorticoid receptor antagonists, there will be no more salt water retentions. Okay, and this is the sympathetic activities. It can be blocked by the actions of beta blockers. Okay, and these are the old mechanisms about heart failure, but there is a newer one recently occurs in heart failure management. Here's it is the nebulizing inhibitor. You can see this if we give ACEI in heart failures, there will be blockage of bradykinins into inactive peptide because Bradykinins is very important for heart failure, and it can lead to vasodilatations and natriuretic peptides, and there will be loading of heart will be reduced. So this is also the important mechanisms. So in bradykinins, substance B, it will lead to inactive peptides by the actions of ACEI. So we don't need that actions. We want the bradykinin actions. So we must block here by the actions of neuroendopeptidases. If we block this pathway, there will be more bradykinases, more vasodilatations effect, and also natriuresis effect. So this is the protective mechanisms of heart failure. So according to these neurohormonal changes, there are some drugs add in chronic heart failure to improve prognosis as well as to reduce mortality. Okay, here, these are the drugs used in heart failure management. ACEIs, angiotensin receptor blockers like losartan, candesartan, and valsartan, beta blockers like, but here is the important thing. Must be selective beta-1 blockers, not non-selected or others alpha and beta blockers. So must be selective beta-1 blockers and nebulizing inhibitor with ARB, CQB3 with valsartan. Okay, but also there is important note. These drugs must be titrated up to maximum tolerated dose, maximum tolerated target to affect the reduce of mortality. Okay, heart failure mortality. So we must give these drugs into maximum tolerated targeted dose. Okay, so this is an important things also. And here's some research and clinical trials based on the management of heart failure with ACEI, with the enalaprate, that is a trial like consensus, and enalaprate also soft and lisinopril with the athletes. So these are the popular and important trial occurs in heart failure management. Okay. Also, there will be the chance and elite for losartan and valhart for valsartan. So this is called mortality benefit drugs in heart failure based on clinical trial. Okay. Okay. Here's this nice guideline for management of chronic heart failure. To manage the heart failure, we must divide into 3 clinical patterns of heart failure. One is heart failure with reduced ejection fractions. Another thing is heart failure with preserved ejection fractions. Also, there is heart failure with mid-range ejection fractions. So we must know the definitions of heart failure with ejection fraction. That is, ejection fraction less than or equal 40% means reduced ejection fraction. Also, these drugs and these clinical trials found in patients with heart failure with reduced ejection fractions. There are some emerging trials and research for heart failure with preserved ejection fractions, but nice guideline recommended for heart failure with preserved ejection fraction is to manage comorbidities like hypertension, atrial fibrillations, ischemic heart disease, and diabetes. Okay, so let's see here. If there is a scenario or there's a question associated with heart failure management, there are some step-by-step management in heart failure. Offer diuretics for congestive symptoms and fluid retentions. Okay, and then these are the mortality benefit drugs. Heart failure will reduce ejection fractions. Here, we must give ACEI and beta blockers. At first, if symptoms poorly controlled after ACEI and beta blocker with maximum tolerated dose, we must add mineralocorticoid receptor antagonists like aldosterone. Okay, if ACEI is not tolerated or if patients are allergic to ACEI, we can choose ARB. But there's no, there's some differences between ACEI and ARB in choosing the heart failure management. Okay, and then if symptom persists despite first-line treatment, this is the first-line treatment of heart failure with reduced ejection fraction management. For first-line treatment, what we consider is to replace ACEI with the CQB3 and zibesardin, this ARNI, ARNI. If ejection fraction is less than 35, stay patient's symptoms and control, we must add, we must replace ACEI with ARNI, ARNI, and we need to add ivabradine with sinus rhythm. This is very important. If patients have atrial fibrillations, there will be no more use. Sinus rhythm with a heart rate of more than 75 and ejection fraction less than 35%. Okay. Here, also we can add hydralazines and nitrate. But this is the important thing. African Caribbean descent, because according to research, African Caribbean descent has a more arterial stiffness than the rest of the global populations. Okay, and here's the junctions for heart failure with sinus rhythm to improve symptoms. So these are the management or step-by-step management of chronic heart failures. So let's review it again. There is heart failure with reduced ejection fractions. First-line medications will be ACEI and beta blockers. If symptoms poorly controlled with these two drugs, we must add mineralocorticoid receptor antagonists. But here is the important thing we need to note it. If potassium is more than 5 millimole per liter, mineralocorticoid receptor antagonist is contraindicated. Although ACEI is not tolerable, we must give ARB. So these are the first-line drugs. If first-line treatments fail, we can consider these management. Replace ACEI with ARNI, add ivabradine in patients with sinus, heart rate more than 75, hydralazines and nitrate if patients is African Caribbean descent, and the digoxins for heart failure with sinus rhythm to improve symptoms. Also, there are some device therapy in heart failure management, like cardiac resynchronization therapy and implantable cardiovascular defibrillators. So what the difference is? CRT is the method of treatment, method of choice in management of heart failure with NYHA class 3 and 4. Implantable cardiac defibrillator on ICD is for NYHA grade 1 and 2, because in case of NYHA grade 1 and 2, most common cause of death is arrhythmia. But in case of NYHA grade 3 and 4, the most common cause of death is pant failure. So we need to give cardiac resynchronization therapy. Okay, here is the one thing we need to notice. Cardiac resynchronization therapy means synchronizations of LV with the RV. So it can be seen in the ECG like QS complex durations more than 130 milliseconds. If QS complex is more than 130 milliseconds, we can add cardiac resynchronization. We can give cardiac resynchronization therapies after first-line management of chronic heart failure. Okay, so these are the nice guidelines about chronic heart failure management. So let's see with this scenario. So this is 56 LV dysfunctions, state symptoms and bed no arrest, that's mean NYHA grade 3, and on ACEI and diuretics. Diuretics has not the ability to reduce mortality. It's for symptomatic control. Okay, so ACEI, ARB, and then mineralocorticoid receptor antagonists. And these are the mortality benefit drugs. Okay, so which of the following drugs will improve patient prognosis? So ACEI already given, and we must choose beta blockers. So the answers will be bisoprolol. Okay. So let's see another example like here. 70 years old May is referred by his GP for management of recently diagnosed congestive heart failure. This is a key point. Already diagnosed heart failure. Poorly controlled hypertension, that will be the risk factor for heart failure. Over the treatments, he has been aware of deteriorating shortness of breath. So there's progressive decline of cardiac output present with dyspnea, autopnea, and fatigue. Over the last minute, he has been comments on the digoxin, 62.5 microgram per daily, and furosemide and amiloride, diuretics and potassium sparing diuretics. Okay, on examinations has a pulse of 96 and blood pressure 130/80, JVB is not raised, and these are the signs of heart failure. Has scattered bilateral crackles on auscultations with display upper speeds and in the anterior axillary lines, 6 intercostal space, that's mean cardiomegaly. Auscultations are had no murmurs, and there is peripheral edema. So that means he was diagnosed with congested heart failures already, and underlying risk factor is hypertension, but symptoms still poorly controlled. And also there is features of signs of heart failure. So if you look at the electrolyte, there is normal sodiums, normal potassiums, and raised urea and raised creatinines and the digoxins normals, because we need to detect the digoxin, serum digoxins level if on the digoxins for heart failure management. When previously his urea has been 11 millimole and creatinine is 110 millimole, ECG shows left ventricular hypertrophy and chest X-ray shows cardiomegaly and calcified aorta, which is the most appropriate next step in management. So here you can see the compared values of urea and creatinine. Current urea level is 30 and the current creatinine is 135. And previous 1 month urea is 11 and the creatinine is 110 millimole per liter. So what would be the next management? So these are questions about chronic heart failure management. So there's a symptomatic treatment with diuretics. So according to NICE guideline, first line drug will be ACEI and beta blockers. So here you can see add an ACEI inhibitor to the current regime, add adenolol at a dose of 25 milligram daily, increase the digoxins to 0.25 milligram daily, furosemide to 80 milligram twice daily, maintain on current therapy. Okay, so and the questions and the answers will be add an ACEI to the current regimes. So before we give ACEI to patients with chronic heart failure, we must know some important facts for initiations of ACEI. That is serum urea, creatinines, and the potassiums. So if you see the current urea and the creatinine level, there will be the little raise of urea and the creatinine than previous 1 month. So should we add ACEI or not? to consider it, you must know human knows the upper limit of urea, creatinines, and potassiums before initiations of ACEA. So the important thing is potassium. If potassium is more than 5 millimole per liter, ACEI is contraindicated. Okay, so here's potassium is 3.5 millimole per liter, and still that urea and creatinine is elevated. That will be the reasons of cardiorenal syndrome. Because of reduced urine output, because of reduced cardiac output, there will be the reduced urinary excretions of urea and the creatinine and show this value. So we can give ACEI in this case because rising of urea and creatinine is not contraindications to initiate ACEI, but potassium is the important fact to initiate ACEI. So the answer will be add ACEI to the current regimens. These are difficult questions. Okay. Let's see another scenario. Here's 82 years old former soldiers with no prior medical history or note was admitted following appendicitis treated with laparoscopic appendectomy a week previously. Okay, no immediate post-op issues of note. Medical teams prior to discharge to address a consistently high systolic blood pressure found to be 160, 170 millimeter mercury with no diurnal variations. Similar readings are obtained from all fallings with lying standing positions. That's according to guideline of hypertension management. A review of his history indicated the patient takes over-the-counter analgesic as required, never require medical care, former smoker. These are the risk factors for the hypertension. Given many years ago, good diet, work with dots 2 months a day, or clinical examinations, U volume and displays a base. That means no target organ damage relative to hypertension. Okay, no papillodemas, urine dipstick, trace of keto, but nothing else. Also, ECG is normal, and other baseline investigations are normal. So, which is the best strategy to manage this patient's hypertension? So, to diagnose hypertension, we must know the NICE guideline. Okay, here is the NICE guideline of diagnosis of hypertension. We must consider clinical blood pressure, also ambulatory blood pressures or home blood pressures monitoring. General thinkings, if clinical blood pressure is more than 140/90 or ambulatory or home blood pressures is more than 135/85, that means hypertension. But to know that, we must consider some cutoff value of systolic blood pressures and the diastolic blood pressures. Here, if clinical blood pressure is less than 140/90, is not diagnosis of hypertension. So check BB every 5 years. Okay. And if ambulatory blood pressures or home blood pressures monitoring show less than 135/85, also we need to check blood pressures every 5 years and more often. That means this is not the diagnosis of hypertension. If we diagnose hypertension, we must categorize into stage 1, 2, and then we will find out some target organ damage. Okay, so this is the NICE guidelines of blood pressures. So if clinical blood pressure is 140/90 to 179/119, and guideline recommends to recheck or for ambulatory blood pressure monitoring or home blood pressures monitoring. To monitor ambulatory blood pressures, it is the device monitoring over 24 hours, and the blood pressure check every hourly, 2 times per hour, and then find out the average values of the blood pressures, and we'll detect it again on the screen, and whether the blood pressure is raised or not. Okay, and then we need to investigate target organ damage and assess cardiovascular rates. So if blood pressure is 140 over 90 to 179 over 119, we need to check ambulatory blood pressure or home blood pressure, target organ damage, and cardiovascular rates. Okay. And then if ambulatory blood pressure or home blood pressure monitoring is 135 over 85 to 149 over 94, that is stage 1 hypertension. Okay, this is the diagnosis of hypertension. So what will be the actions for this blood pressure? If age is more than 80 and clinic blood pressure is more than 150 over 90, lifestyle advice maybe consider drug therapy like antihypertensive medications. And if age is less than 80, with target organ damage like cardiovascular death, renal disease, diabetes, or 10 years cardiovascular death risk is more than or equal to 10%. Also, lifestyle advice, and we need to start antihypertensive medications. If age is less than 60, with 10-year cardiovascular risk is less than 10, offer lifestyle advice and consider drug treatments. If age is less than 40, this is the important point for hypertension management, because if age is less than 40, we need to consider young hypertension. Young hypertension means there will be the underlying cause of hypertension, like secondary hypertension, like renal cause or endocrine cause of hypertension. Okay, so these are the step-by-step algorithms of blood pressure diagnosis. Okay, so if we see this if clinical blood pressure is 180 over 120 or more, we need to consider drug therapy immediately. We need to start drug treatment immediately without ambulatory or home blood pressure monitoring. And then review the clinic's 7 days of drug therapy, or refer to same day with hypertension specialists, because this blood pressure is associated with the target organ damage like hypertensive emergency. Okay, there's retinal hemorrhage, bubble edema, or accelerated phase hypertension, or life-threatening symptoms and raising creatinine, maybe more. Okay, if ambulatory blood pressure or whole blood pressure monitoring is 150 over 95 or more, this is stage 2 hypertension. So how will you manage this case? Like this stage 1, if age is less than 40, we need to consider special evaluations to find out the secondary causes of hypertension. Okay, so these are the diagnoses of heart failure according to NICE guideline. So you must know the target range of blood pressures, like clinical blood pressures, also ambulatory blood pressure monitoring or home blood pressure monitoring. These are the steps for the management of heart failures, and let's talk about it in the later slide. Okay. So if we see this scenario again, you can see the current systolic blood pressure is 160 over 140, repeated readings during the course of the admissions, no diurnal variations. That means clinic blood pressures. If clinic blood pressure is 160, 170, what will be the management? Okay, so if clinic blood pressure is 160 over 160 and 170, the answer will be offer ambulatory blood pressure or home blood pressure monitoring according to NICE guideline. Okay, so the questions will be, the answer will be ambulatory blood pressure monitoring. This is the diagnosis of hypertension according to NICE guideline. Okay, so let's see another scenario. Here, 61 years Caucasian patients present at the busy outpatient clinic. She has a hysterectomy in her 40s for symptomatic fibroids following complications of her family and developed preeclampsia in both of her pregnancy. This is the complications of hypertension. Current and lifelong smokers. There's a risk factors. And the present medications is steroid containing, estrogen pill, and salbutamol, and serotype. On examinations, blood pressure is 145/90. That's a clinic blood pressures. And chest auscultations were normal. Examinations otherwise unremarkable, and others baseline investigations normal. Which additional strategy would you advisable with respect to her hypertension? Okay, so we need to consider whether it's hypertension or not, and we'll give the antihypertensive drugs or not. Here, in this scenario, there is blood pressure is 145/90. Okay, so what the important things at the clinic blood pressure measurement is, we need to measure 3 consecutive blood pressure with lying, standing positions, and each measurement interval is 1 minute. And we will take the average of systolic and diastolic blood pressure after 3 consecutive measurement of blood pressures. Here is the one-time measurement of blood pressure at the clinic. So the answer will be repeat blood pressure later, because blood pressure measurement is very important to diagnose hypertension. So accurate measurements of blood pressure is crucial. So according to NICE guidelines, what they recommend is to monitor blood pressures at the clinic, we must take 3 times and the interval of 1 minute. We will take the average of systolic and diastolic, the lowest value of systolic and diastolic. And we will know its X clinic blood pressures. If clinic blood pressure is 140/90 and hypertension is likely, if clinic blood pressure is 140/90 to 179/119, we must offer ambulatory blood pressure monitoring or home blood pressure monitoring. Also, we need to find out target organ damage and assessment of cardiovascular death. Okay, so the answer will be repeat blood pressure later, because this is the one-time measurement of blood pressure at the clinic. We need to repeat 2 times to get the accurate clinic blood pressures. Okay, so let's see another scenario. Here, 56-year-old Caucasian man attend for his annual hair checkup at the GB surgery. Past medical history of hypertension and gout. His work and does not complain of any headache, visual changes, or chest symptoms. Blood pressure is 165/95. Currently on ilobutanol and maximum dose of perindopril. Which of the following is the most appropriate next step management for his hypertension? So here, the important points in this scenario is hypertension and gout as a past medical history, but there is no urgent indications to reduce blood pressures. That means there is no target organ damage, and the blood pressure is current blood pressure is here already on ACEI. Which of the following is the most appropriate next step management for his hypertension? Okay, so let's take a look at nice guideline of hypertension. This is a step-by-step management of hypertension. We need to categorize into hypertension with type 2 diabetes or hypertension without type 2 diabetes. If there is hypertension with type 2 diabetes, the first line drug will be ACEI or ARB, because in case of type 2 diabetes, there will be microalbuminuria, and ACEI or ARB is the only drug that can reduce microalbuminuria, and it has some effect on cardiovascular death. Okay, if patients without type 2 diabetes were categorized into 3, like age less than 55 and not of Afro-Caribbean family descent, and age is 55 or over and Afro-Caribbean descent. So if we see this, age is less than 55 and not an Afro-Caribbean, because if in scenario, it's given that patient is Afro-Caribbean descent, the first line drugs will be calcium channel blockers, although age is less than 55. Okay. Here, age is less than 55 and not Afro-Caribbeans, the first line drug will be ACEI or ARB. If age is less than 55 or over or Afro-Caribbean descent, the first line drugs will be calcium channel blockers. So here's a step 1 management of hypertension. And then if pressure is not controlled, so we must know the target blood pressure range according to age. Here, blood pressure targets, if age is less than 80 years, clinic blood pressure is less than 140 over 90, ambulatory or home blood pressure is less than 135 or 85 is the target blood pressure. And age is more than or equal to 80 years, blood pressure, clinic blood pressure is less than 150 over 90, ambulatory or home blood pressure is less than 145 over 85. This is target blood pressures for older than 80 years. Okay, we must know step-by-step management of hypertension, whether it is on the target or not. Okay, so after giving step-line treatment, we must see the target blood pressures according to age. If it's not in the target range, we will add another drugs. Like if first line is ACEI or ARB, and the additional drugs will be calcium channel blockers or thiazide-like diuretics. That's the important things. Thiazide-like diuretics, not thiazide type diuretics. So we need to know what are the thiazide-like diuretics and what are the thiazide type diuretics. Thiazide-like diuretics mean indapamide and the metolazone. And thiazide type diuretics mean hydrochlorothiazide and benzopyrrolmethiazide, and it's end with thiazide. Okay, so and you can see this group. If first line is calcium channel blockers, and additional drugs will be ACEI or ARB or thiazide-like diuretics. So after step 2, we'll review the target blood pressures. State and control, we'll add another drugs like ACEI or ARB plus calcium channel blockers plus thiazide-like diuretics. That is step 3. Okay. After step 3 management, what we need to consider is resistant hypertension. Resistant hypertension means additions or trade drugs to control blood pressures, including thiazide-like diuretics. Blood pressure stay and control. That's its resistant hypertension. So after step 3, blood pressure is uncontrolled, we need to consider step 4 management, including resistant hypertension management. So after step 3 management, what we need to look at is the potassium level. If potassium is more than 4.5, additional drugs will be alpha blockers or beta blockers. If potassium level is less than or equal to 45, we need to add low dose aldosterone. Okay, also seek advice if BP is uncontrolled on optimal tolerated doses of 4 drugs. Optimal tolerated dose. That's also the important point for hypertension management. We must be titrate up to maximum tolerated dose to control hypertension. Okay, so this is the step-by-step management of hypertension according to NICE guideline. So look at this scenario. Pressure is stay and control with ACEI, and additional drugs will be calcium channel blockers. Okay, so the most appropriate next step management for his hypertension is calcium channel blockers. But here's the options like calcium channel blockers or thiazide-like diuretics. What we need to consider is she has cough. So thiazide-like diuretics is contraindicated in patients with cough, so we will add calcium channel blockers. Okay. Let's see that scenario. You are seeing John, a 56-year-old man who is complaining of central constricted chest pain. Walking up the stairs trigger the pain on exertions. Central chest pain, trigger the pain, goes away with resting. Experiences some shortness of breath but denies any syncope or palpitations. Here's the risk factor like hypertension and diabetes. Also, comorbid like migraines already on verapamil. And his other medications is GDN spray, aspirin, atorvastatin, ramipril, and metformin. On examinations, rather than it's irregular, other examinations normal. He's asking for the medications that will be helpful to prevent the chest pain from occurring. What is the most appropriate treatment? Okay. To answer the questions about angina management, we need to find out, we need to differentiate between stable or PCS. So let's see with this example. Stable angina versus acute coronary syndrome. To differentiate stable angina versus acute coronary syndrome, we must know some clinical important facts like pain on exertions, and pain in cardiac sound like pain, and relief after resting. That's the important point to diagnose the stable angina. In case of ACS, in acute coronary syndrome, we also differentiate into stable and stable or myocardial infarctions. Myocardial infarctions, which can be divided into non-ST elevations, MI, and ST elevations, MI. So what will be the differences? Difference between stable and acute coronary syndrome is stable angina has a pain, central constricted pains on exertions and relief by rest, not in the stable angina. Stable anginas, there will be the progressive pain and not relief by rest and not relief by GDN spray, and there will be increasing pain But cardiac biomarkers will be normal. In case of myocardial infarctions, there will be constricting chest pain associated with autonomic symptoms like nausea and vomiting, and raised cardiac biomarkers. So we need to differentiate these definitions to answer the scenario. Okay, so you see this, there's a central constricting chest pain and triggers the pain during exertions, goes away with rest. So that means the patient had stable angina. Okay, so it's not the diagnosis of acute coronary syndrome, and diagnosis will be stable angina. Okay, so what will be the questions? The questions is chest pain. To prevent chest pain from occurring, what is the next appropriate treatment? Okay, to answer these questions, we must know a step-by-step management of stable angina pain. Look at this. Stable anginas, lifestyle modification is the first line treatment, like reducing weight and avoid smoking and moderate alcohol consumptions and reduce salt takings and short-acting nitrates for symptomatic relief. Okay, for medications to preventions, as a secondary preventions, we can choose beta blockers or calcium channel blockers. Important thing is when medications may be introduced at first, beta blockers or calcium channel blockers. If not tolerated or there is contraindications like asthma, we do not choose beta blockers, and we choose to nitrate, long-acting nitrate, evaporatins, nicorandin, and ranolazines. These are the vasodilating drugs. And if stay symptomatic after beta blockers or calcium channel blockers, we can combine beta blockers with calcium channel blockers. But here's important things we need to note it. Combinations of beta blockers with calcium channel blockers leads to myocardial separations and hypotensions and a shock. So we need to avoid it. We need to take care of adding beta blockers with calcium channel blockers. Okay. If stay symptomatic after 2 anti-angina drugs, we would choose revascularization therapy like PCI or CAPG. But the difference between PCI and CAPG is single vessel disease. If multivessel disease less than 65 years and suitable anatomy, we choose PCI. If unsuitable for anatomy, multivessels, and patient has diabetes, we choose CAPG. So this is the algorithm for management of patients with stable angina. So let's see this example. This is the stable angina management. Chest pain stay present, and then pain to prevent the chest pain from occurring. We need to consider another drugs. Okay, because he's already given GDN spray. Okay, GDN spray. So, and the second line drugs will be beta blockers or calcium channel blockers. So we choose between these kinds of drugs. So, sorry. In its scenario, and the answer will be sorry. So in its scenarios, and the answer will be the nicorandins. Okay. Okay. Let's see another scenario. Which of the following non-invasive methods provide the most accurate assessment of whether the patient has coronary artery disease. Number one, contrast enhanced cardiac CD. Two, cardiac MRI with gadolinians. Exercise ECG, cardiac spreads with reversibility studies. Trans-esophageal echocardiography. Okay, we did choose the different investigations to diagnose stable angina. So that's main coronary artery disease. To diagnose stable angina is very important. There are some investigations to diagnose stable anginas, but there are some advantages and the disadvantages to diagnose it. Let's see it. The very first investigations to diagnose stable angina is ECG. In ECG, we can see planar or downsloping ST segment depressions of 1 millimeter or more. That is ischemia. But that's not always present in ECG in patients with ischemic cardiac disease. So ECG is not a specific one to diagnose stable angina. And another example, another investigation is exercise ECG. That to perform exercise ECG, patients must be stable. If patients unstable or current MI, it is contraindicated. And it must be already known coronary artery disease. And then another investigation is CT coronary angiogram. It is the non-invasive method to diagnose ischemic heart disease. And also there are some investigation like non-invasive functional imaging stress echo by means of dobutamines or adenosines to look the coronary vessels during cardiac muscle contractions, and myocardial perfusion scanning, and SPECT scanning, MR imaging for stress-induced wall motions abnormality. These are the investigations for coronary artery disease like stable angina. Okay, this is the invasive one to diagnose stable angina. It is coronary angiogram, but it's usually performed when coronary artery bypass graft surgery or PCI is being considered. This is an invasive one to diagnose coronary artery disease. So there are different ways to diagnose coronary stable angina, stable coronary artery disease. So what would be the one? What would be the best one to diagnose coronary artery disease? So it's very simple. We just need to follow the NICE guideline. NICE recommend the following to diagnose coronary artery disease. Symptoms must be consistent with typical, atypical angina or ECG changes. So what the difference between typical and atypical angina? Okay, let's see this. Definitions of typical angina means if the patient has central chest pain, and the pain is occur during exhaustion, and it's relieved by rest, or after given nitrate, that's called stable angina. If we meet the criteria 1, 2, 3, it is called stable angina. Atypical angina means patient meets the criteria out of 3, 2 out of 3 criteria, that is atypical angina. If patient has not the criteria like central chest pain and pain on exertion and relief by rest, that is called non cardiac pain or non-angina pain. So we must know the definitions of typical, atypical, and non-cardiac or non-angina pain. Okay. So typical or atypical angina or EC changes. As I mentioned above, EC changes will be the blender or downsloping. That's about depressions of acidic segment 1 millimeter below the isoelectric line. So there's an EC changes or ischemic cardiac disease. If we found that typical atypical angina or EC changes, we'll move on to get the diagnosis of ischemic heart disease by means of first line, second line, and third line investigations. First line is CD coronary angiography. That's a non-invasive one, as I already mentioned above. And the second line is non-invasive functional imaging, looking for reversible myocardial ischemia. And third line is invasive coronary angiography. So that's a very simple method to diagnose, to know the stable angina of coronary artery disease. NICE guidelines do not recommend exercise ECGs to diagnose stable coronary disease. Okay. Okay, I will remove it. So these are the same scenarios commonly as in MRCP exams, and already discussed about the guideline management and step-by-step management according to NICE guideline, and the same important scenario for MRCP exam. So today, that is the same scenario of cardiovascular assistant for MRCP. Let's see in the next video. And if you like this video, and if you like my channel, please hit the button, like, and subscribe to my channel. Thank you.